any ado, we shall go on to our first speaker, Dr. VINEET JOSHI, a young consultant ophthalmologist from LV Prasad, specialist in cornea anterior segment and cataract surgery. And he is going to tell us something very quintessential to this whole webinar. How do we recognize an early ectasia and what is the importance of refractive surgical screening? On to you, Dr. VINEET.
Thank you, Dr. Chitra. Thank you, AIOS and ARC for this opportunity, and I welcome all PGs on this session. So I would like to talk on this topic of early ectasia diagnosis with a very simplified approach. Just to go ahead with, if when we talk about ectasia, what really comes out in your mind are the textbook terminologies, the paragraphs that go through our keratoconus, PMCD, keratoglobus, TMD, and nowadays post-Lasik ectasia. But reading that is different, but how to correlate those, its importance clinically, and how to tackle some of the questions that might come in the exams. It's interesting to understand this, the clinical approach in between. Post-Lasik ectasia has gained a lot of attention in the last few years. Although it was found out in some of the articles, its prevalence to be about 0.04 to 0.6%, but this is highly underestimated. And I think in the upcoming studies, we would find out that it's not so. And basically, it's a result of weakening of the biomechanical stability of the cornea as a result of any ablative procedures like LASIK, where we are giving a cut into the anterior 1/3 of the cornea. For an example, have a look at this case where the 23-year-old patient underwent PRK elsewhere, and he presented again with blurring of vision in the right eye. And you can see his anterior sagittal map towards your top left, that there is some amount of steepening that is ongoing in the somewhat inferior paracentral region. And you can also see a contralateral flattening there. This could be an decentered ablation, but if you correlate now that with the back elevation and the pachymetry, there is certainly definitely going wrong, something wrong. And the posterior elevation and bad display also highlights the pointers, where so it kind of ticks all the flag signs, and you should consider this as one of the post PRK or post refractive surgery ectasia. This is in the left eye. You can see that the sagittal map looks pretty much fine, and so is the posterior elevation bad display. These were the preoperative maps of the same patient, and you can see here what was missed in the axial sagittal curvature map is the prominent inferior and superior asymmetry. There is a difference of around almost 3 diopters of there, and I think that was not picked up, and this which was absent on the left side. So this case highlights the importance of screening of any case before going for any laser refractive surgery. Now, there can be 3 scenarios. First is that the cornea could be absolutely normal clinically, topographically, and then when we plan to take it for surgery, overall, after some period of time, it manifests with ectatic changes. Second possibility, there are some preoperative changes which point towards a weakness in the cornea, and this biomechanical fragility is towards some minor topographic changes. And the third possibility is that where you have used a lot of ablation or where you have ablated a lot of tissue leading to weakness. The ectasia risk scoring protocol put forth by Randleman identifies topography as one of the most important factors. The anterior topography map, the sagittal map with inferior steepening is one of the most important risk factors. Residual stromal bed thickness to add to it, and age and high myopia happen to be other factors, where in younger age is a kind of a risk factor. And if you follow this particular chart, it kind of builds a map for you as to how many points you should look at when you screen a particular patient. Early ectasia where you miss out is the subclinical keratoconus, where either a form thrust or keratoconus suspect is something that you should look out for, and the telltale signs of the same. which are basically the early topography signs. Now, it could be inferior superior asymmetry, look for inter-eye asymmetry, steeper keratometry, against the rule astigmatism, and the front and back elevation maps, and look for red flags there. In tomography, newer technologies shows in bad displays, there are already flags placed based on the newer AI technologies, and posterior elevation, which is put forth by Bellin Ambrosio display, where you can see that I'll show in the next few cases how important that particular parameter is. Percentage tissue altered is one very important parameter. It was not included in the Randleman score, but I think it has a significant importance in cases which are normal to begin with, and a value of around 40% has a very good relationship between the biomechanical stability of the tissue, the thickness, ablation depth, and the flap thickness. And I think this is something which should be calculated in cases where you are anticipating larger, where there is a larger refractive error. This is one parameter you should always keep in mind. 250 microns as a residual bed thickness was identified in 1998 by Sealer et al. And there were reasons for the same, but now the recent study shows that this can vary up to 288 to 300 microns. So you have to watch for other signs that come along with it. It has to corroborate clinically with central corneal thickness as well. A typical clinical flag sign of less than 500 microns should alarm you to look for other signs. And other factors, which are chronic trauma, eye rubbing, family history of keratoconus, refractive instability, and preoperative best spectacle corrected visual acuity of less than 20/20. Now, what I would suggest is a fast check in a clinic is go through this in any patient. Look at the age. What is the age? Is it in early 20s or late 20s? Ask for eye rubbing and allergy. If the vision is not improving to 20/20 or N6, look for the asymmetry in the refraction, in the visual acuity. Look for the refractive error. What is the cylinder power? Is there asymmetry there? Then look at the maps. Look at the topography map first, look at the sagittal front elevation, back elevation, look for the red flag signs, see the pachymetry then, and then if you have epithelial mapping, very well, good enough. And lastly, then look at the bad display. Once you follow this, you will never miss out at risk case. Look at this patient, 25-year-old patient came for refractive surgery, even highly motivated. You can see here his refraction is again asymmetric. One eye is having higher cylinder power, and if you see at a glance, you can see that there is some amount of inferior superior asymmetry and some amount of steepness, more in the axial maps on the right eye more than the left eye. When we probed the history of eye rubbing, he did give history of dust allergy, and as you can see in the bad display map, there is a significant posterior elevation, and we had to ask him to wait and repeat the scans after 6 months, avoid eye rubbing for the same, and he was advised against the refractive surgery at this visit.
1 minute remaining, sir.
Yes. Similar to that, this one case, again highlighting the importance of steep keratometries, thinner pachymetries, and telltale flag signs in the bad map. Now, coming to this third case, you can see the refractive error is pretty high here. And the pachymetry is also well below 480 with inferior superior asymmetry, but the elevation maps are pretty much fine. Now, there is no posterior elevation. Now, this is a borderline case. Some people might want to go, some people might not want to go for refractive surgery in this one. But the inferior superior asymmetry is a little bit on borderline, and the pachymetry is well beyond 480. It's below 480. So that is the reason we didn't opt for surgery in this case. Another important finding, which I wanted to highlight, I'll put that in the last case. Some false positive cases are where we have seen that if the white to white is less than 11.2, and if the corneal thickness is more, you would not find any telltale sign in the anterior maps, but there will be some changes in the posterior elevation. Most of these patients actually do well after refractive surgeries. And this is actually one of the false positives. I just wanted to add it to the list of the patients. So to just summarize, what I would again highlight is that you should take home is to look at this particular quick check in an OPD, which will help you to catch any case and review it in the clinic before you plan for any refractive procedures. Thank you.
Thanks a lot, Dr. Vineet. You highlighted all that was very essential and critical for us to know. Before I ask Radhika to take the next question, I'm going to ask Dr. Vanity. Would you, when everything looks okay on the topography on the pentacam, but there is something which is there on the corvis, the red flags, would you attach importance to that? And then would you veer away from a corneal-based surgery and do a phakic IOL in this patient? Or what would you do?
Okay. I think this is the commonest dilemma which we always face, Dr. Chitra. And one thing which we have to bear in mind is the artificial intelligence software on the dynamic corneal imaging used the Caucasian data to establish its normatives. So I think applying it and extending it onto the Indian database. So we are looking at Asian eyes and we know that our parameters would be slightly different. But that again is an assumption, maybe it is not. But I would not, as a hard and fast rule, look at the corvis when it's red flagging. I would also look at the amount of red flagging and how it is based on, and in depth look at the various topographical indices, which would probably, give me an indication. Look at your apex positioning, look at the displacement of the apex positioning, look at your topographic mapping, look at your Kmax parameters in comparison to K1, K2. So there are certain fine aspects onto this. And always do explain to your patient that, the software is red flagging you. But upon a very extensive clinical examination, we feel that you could go ahead, but there is no 100% surety of how his or her cornea is going to behave, how his or her biomechanical strength is going to return following the healing process. So that's something which a clinician needs to approach in as a custom approach or as a case-based approach.
So I'll ask that. I totally agree. I'm going to let Radhika take the next question. If time permits, I'll ask one controversial question.
Yeah, so this is an excellent topic, very well covered by Dr. Vineet, because our PGs, we get this as an exam question, and this is something that they will face in their future practice if they take up refractive surgery, how to screen the pre-refractive patient. So my question to either Dr. Vineet or Dr. Sudhir, who wants to answer this, would be that Dr. Vineet nicely elucidated the list of checklist. So it's not always black or white. If all the checklist points are okay, we proceed with the treatment. If many are red flag, then we don't do the treatment. But quite often in real life, we see that, one or two parameters are amiss, like, a little superior inferior asymmetry, a little increased back elevation, all other parameters are okay. Having done it, you don't want to proceed either because these are fully sighted patients, but they're not so, off the target that you don't advise the treatment. So what do you do for those patients who have a few parameters which are red flag? Do you tell them no treatment, or do you wait it out to see how it would progress? What would you be advising them? Dr. Sudhir?
Yeah, basically whenever there are suspicious cases where we have one or two parameters which are not aligning with our thing, then what I would generally do is wait for 6 months or repeat the test and at a different day. The first will, so that if these are because of some intraoperative variations because of the examination, that can be nullified. And if these are not repeated again, then we can consider and give benefit of doubt to the patient. Other option is to wait for 6 months to see if there is a change in these parameters. And then if there are no change, then go ahead. And if still patient is very keen and if they are in borderline, I would go for a PRK with all these parameters kept in mind, so that we are not exposing the patient to more risk factors. So that will be my...
I agree. And if it were a corvis having some of those minor red flags, the pentacam looks really neat and clean, then we would do a PRK extra for these patients. So that was my controversial thing. Like I do believe that yes, PRK is the only possibility after following all the precautions which you did mention. But we've had very consistent good results with our doing a cross-linking combined with surface ablation. I don't see it makes too much sense if you're doing a LASIK extra, because cutting a flap in these cases makes absolutely no sense. But I don't know whether we have any other takers in this amongst the speakers? Or Ritika, would you all be doing PRK extra in your center? Or Pooja, would you be doing it?
Ma'am, as you said, I definitely agree with you. If it has to be an extra procedure, it's always with PRK rather than the LASIK, because when you cut, you're doing LASIK, you're creating a cut of around 20 millimeters.
Yeah.
That itself is creating the weakening. So anytime PRK extra would be better in this kind of cases.
I think we'll go on to our next